Hello, everyone, and welcome to the workshop today. And I hope you will enjoy today's lecture due to some of my own traveling. I've turned my video off because I cannot turn it on. So I hope you can understand it very well. And the certificates will be issued to you by my collaborators. So please do send a message to Dr. Nasrullah for to get your certificates. Okay, I'm sharing the number of Dr. Nasrullah, so kindly WhatsApp him once the webinar is over to receive your own certificate. Thank you. Hello, everyone. Can you hear me? Can you please tell me you hear me? Okay, thank you very much. Professor Georgios Matters is here. Welcome, sir. It's so good to see you today.
Good evening. Hello.
Good evening, sir. Sir, I'm sorry I'm traveling, so I could not turn my video on. I'm currently
No problem.
traveling. Thank you very much, sir. It's a pleasure to see you again. You are a real inspiration for many of us, and we've been following your wonderful posts and all the updates that you have been doing on the Facebook and all other social media platforms. So it's a great honor to welcome you today. I really wish to say a couple of words for you because everyone is really knows you, and you are really a huge figure of inspiration in our specialty. So, everyone, please help me welcome Professor Georgios Matters, who is a senior consultant for neurosurgery and leads the chronic pain and spasticity sector of the Department of Stereotactic and Functional Neurosurgery in the University Hospital of Cologne. And you can see he's a very, very active neurosurgeon and always, looking for innovation. And this is, I'm personally a big fan of Professor Georgios Matters, and it's my second time that I'm hosting. I'm having the honor of hosting Professor Georgios Matters lecture, Sir, thank you very, very, very much for sparing your time. I know you have a very busy schedule, but thank you very much for joining us today. It's a huge honor to have you here with us today to deliver a very important talk on, endometriosis, pelvic pain, and neuromodulation. I believe that every neurosurgeon should know about this because neurosurgery should not be limited to only a few of the things. And I believe that we need to expand our wings and involve as many things and to show our involvement, our help into other, we should need to collaborate and help other people of other specialties and people. Obviously, pain is our field; it should be our field. So I believe that from neuromodulation, of course, is comes should come into our domain and should be done. Thank you very much, sir. The podium is all yours now. Thank you so much again.
Good evening, everybody. Thank you very much for your kind words. It's always a pleasure to speak about neuromodulation, especially about spinal cord stimulation. I'm just trying to raise awareness about these therapies. I believe it's pretty late there. Here in Cologne, in Germany, it's 5 o'clock in the evening, but I assume where you are now, it's a little bit
Yes,
later. So I will try to not to take so much time, and I will try just to give you an overview of this topic. Please let me share my screen and please let me know if you can see my screen now.
sir, we can see your screen now. Thank you
Perfect.
very much.
Then let's start the topic, and I'm really happy that you invited me to speak about it. It's about endometriosis and pelvic pain in general. This is a topic that it's not really famous out there in the neuromodulation world. There are not many colleagues that are active in this domain, and this is a good time to raise a little bit awareness about this condition as well. So my conflicts of interest, I'm consulted for many, many companies. Some of them are listed here, but I don't think it's really relevant for this presentation. Spinal cord stimulation. Most of you would know that everything started in 1965 with the famous gate control theory published in Science, a very prestigious journal. And this theory says or said back then that if we activate the big diameter alpha beta fibers, then we can stop the transmission of pain signals to the brain. This theory is not completely correct, but is the basis of all our neuromodulation therapies. The first clinical application of spinal cord stimulation now took place in the United States in 1967, more than 50 years ago, so this is not a new therapy, and it was in a patient with a lung cancer. Interestingly, the daughter of the patient was working in the anesthesiology department. She was a nurse and convinced her father back then to undergo this therapy because back then it was really experimental. The patient was satisfied. He could achieve a very good pain relief, but unfortunately, he died 6 days later because of endocarditis. The number one indication for spinal cord stimulation is this persistent spinal pain syndrome. The older name was failed back surgery syndrome. It is pain in the back or in the neck, in the arms, or in the legs after a surgery in the spinal column. This is 80% of the patients that are coming to our outpatient department. But this is not the only indication. There are many more. We have patients with complex regional pain syndrome. This is a condition that unfortunately is not well known worldwide. As a medical student or as a resident, I never heard about it. We have patients with refractory angina after bypasses, after stents, after all medications. We have patients with painful diabetic neuropathy, and we have also patients with pelvic pain and abdominal pain. What's really interesting in the literature is that if you read these articles with the title pelvic pain, you will see that some of them are referring to abdominal pain. And if you read some articles with the title abdominal pain, they are referring to pelvic pain. So we really must be a bit careful because pelvic pain and abdominal pain is not the same thing. Nevertheless, in many publications, You can see both terms for two different conditions. There are many review articles out there. Most of them are really good. One of them was published in Nature Reviews 2019. It's about gastrointestinal disorders and neuromodulation. You see how many options we have, for example, gastric electrical stimulation or sacral nerve stimulation, and many, many other things. If you have some time, I would suggest that you read this article. There are many good images as well. What about chronic pelvic pain? The definition, it's a persistent, non-cyclic pain located within the pelvic region lasting longer than 6 months. It affects 5 to 26% of females, but also 2 to 16% of males. We have a variation in patient presentation. We have, unfortunately, a gap in the communication among specialties. We have an underreporting of the syndrome, and we have a lack of standardized diagnostic criteria. The mechanism of this pain is really complex. And it's complex because we have many pain generators. A very nice article in Pain Physician. You see some of these generators. They could be visceral. For example, we have an abscess or proctitis or hemorrhoids or anal fissures. Could be urologic, for example, prostatitis. It could be reproductive in women, endometriosis or vulvodynia. In males, we have epididymitis. We have neurologic conditions like disc herniation or pudendal neuralgia, musculoskeletal problems such as coccydynia or fibromyalgia, and the most important one that should we not forget are the psychosocial factors. There are many patients out there with depression, anxiety, post-traumatic stress disorder, or even sexual abuse that could come to our outpatient department and say that they have pelvic pain or abdominal pain or some other type of pain, and nevertheless, it's not somatic, the problem, it's psychological. We should be aware of this as well. In the neuromodulation, we have many targets. It depends on the condition we'd like to treat. For example, if we have to treat interstitial cystitis, we have to stimulate S2, S3, S4. If we have women with vulvodynia, we would like to stimulate S2, 3, 4, or 5. Pudendal neuralgia, this is a common condition and underdiagnosed, then we'll have to stimulate roots S2 to S4. If we have pelvic pain, and we have many such patients, we'll have to stimulate the second and the third sacral root. Milestones. It was in 1972 that sacral neuromodulation progressed to the laboratory stage, and it was 9 years later, 1981, that a clinical trial of sacral nerve modulation for the treatment of voiding dysfunction and pelvic pain was launched. And let's talk a little bit about guidelines. Here we have a problem. All of these therapies, this sacral nerve stimulation or spinal cord stimulation or other modalities that I'm going to show you in the next slides are really helping the patients. According to the guidelines, they are not helpful. This guideline is coming from the German Society for Psychosomatic Gynecology and Obstetrics, published in 2022. And you see that in this guideline, the authors are writing for treatment in chronic lower abdominal pain, and they include pelvic pain here. Neuromodulation and neurolysis are considered experimental procedures, and their use is not recommended outside of studies. The next guideline comes from the European Association of Urology, 2023, for primary bladder pain syndrome. The authors are writing here that sacral neuromodulation may be effective, pudendal nerve stimulation is superior to sacral neuromodulation, and that we should offer neuromodulation before more invasive interventions. For primary anorectal pain syndrome, the authors are saying that sacral neuromodulation is effective and that should offer neuromodulation but with a weak strength of rating. UK 2017, NICE, National Institute for Health and Care Excellence. The title is Neuromodulators in Neuropathic Pain Treatments, but actually this guidelines includes only medications, pharmacological treatments. There's nothing there about neuromodulation, about devices. Australia, 2021, guidelines for endometriosis. Here you can see the authors are writing something about neuromodulators, and with neuromodulators, they mean medications and devices. But if you read this guideline, you'll see that the only thing that is mentioned there is the TENS therapy. There's no spinal cord stimulation or other neuromodulation therapies. European Society of Human Reproduction and Embryology, published in 2022. Here the authors are writing something about electrotherapy, and they actually mean transcutaneous electrical nerve stimulation, TENS, and acupuncture-like TENS. And they're writing, in summary, no recommendation can be made based on the studies regarding electrotherapy and the effect on quality of life or pain in women with endometriosis. They are also writing in this section, surgical interruption of pelvic nerve pathways, that there are two options: this laparoscopic uterosacral nerve ablation, LUNA, LUNA, and the presacral neurectomy, PSN. And they are concluding that LUNA is not beneficial. PSN is beneficial, but it is associated with increased risk of adverse effects. So it doesn't look really well. What about the famous Cochrane reviews? For all these years, 1999 to 2023, we have 29 reviews about pelvic pain, neuromodulation, and other options to treat pelvic pain, and we have only 6 reviews which are directly referring to endometriosis. So there are not so many things published out there. If you visit the Journal of Neuromodulation, the official journal of the International Neuromodulation Society, with an impact factor of 3, and you search for endometriosis, you will find only this abstract: spinal cord stimulation for treatment-resistant abdominal, visceral, and neuropathic pain related to endometriosis. It's a feasibility study. Review articles about chronic pelvic pain. There are many articles out there. There are many systematic reviews with many forest plots by condition, for example, chronic pelvic pain or pudendal neuralgia. There are also forest plots by treatment, peripheral nerve stimulation, or TENS, or sacral nerve stimulation, or spinal cord stimulation, and they all show that all these therapies are actually helping. This is a case series published in 2021, United States, with spinal cord stimulation, dorsal root ganglion stimulation, and intrathecal therapy. And you can see that the pain NRS scores are reduced. The ODI, the Oswestry Disability Index, is less, so patients can function much better. And the PCS, this catastrophizing scale, has some lower values, meaning that all patients are improving with these therapies. A very nice review article published in Pain Medicine 2020 about visceral pain and spinal cord stimulation. What's really important here is the placement of the leads. And the authors are saying that we should place the lead between the fasciculi gracili, because there we find the actions that are involved with the pelvic and lower abdominal viscera. Leonardo Caporal published this article 10 years ago about spinal cord stimulation mechanisms of action, and he wrote here that some of the mechanisms are the release of inhibitory neuromodulators, the blockade of nerve conduction by antidromic activation, the direct stimulation of the postsynaptic visceral dorsal column pathway, the downregulation of segmental or supraspinal sympathetic outflow. And we have some novel targets. Another publication, Falowski, Hunter, in Current Pain and Headache Reports, we can place our spinal cord stimulation lead at T5, T6, so a mid-thoracic stimulation. It seems that this region may be an important access point for visceral inflow. This is why we stimulate at this level for chronic pancreatitis pain. And if you remember the anatomy, the neuroanatomy, the sacral fibers are positioned medially, so we will have to place our lead in the middle line. The second option is to stimulate cones, so we have to place our lead a T12, L1, L2, where you can see the cones on MRI images. Why? Because in this region we have a wide distribution of nerve roots, but the stimulation could be inconsistent because of the increased mobility of the cord at this level, and because at this level we have much more cerebrospinal fluid. We have the traditional spinal cord stimulation with paresthesias, with tonic stimulation. We also have the subperception spinal cord stimulation without paresthesias, without tingling cessation. And one of these subperception waveforms is this 10 kilohertz, 10,000 hertz stimulation. A pilot study published in 2021 showing that the pain disability index score is reducing, the VAS score is reducing, and the remitter rate is about 62% after 12 months. Pretty good results. Another case series with 10 kilohertz stimulation as well from the United States, 2017. Please have a look at the last column. We are speaking here about a pain relief of 50%, more or less. It's not that we can offer our patients pain relief of 100% or 80%. Usually we can offer something between 50 and 80%. What about patients with Tarlov cysts who are already operated on, or patients who have this Tarlov cysts and they don't want to get operated on? This is a case report after Tarlov cyst surgery. You see two leads placed in the spinal canal with the uppermost contact at the lower end of T7. We could try this option, the spinal cord stimulation for patients with multiple pelvic fractures. We can try with tonic stimulation, we can try with subperception with 1000 hertz. It's not only the pain score that becomes better, but more importantly, the quality of life improves, and many patients don't need any medication anymore, or they need much, much less. Dorsal root ganglion. There are some case series in the literature. You see here 4 leads. 2 leads are placed at L1 and 2 leads are placed at S2 at the same time. So we have 4 DRG leads in the same patients. And you see the pain scores before the trial and after the trial. So the results are pretty impressive. But please keep in mind you have to implant 4 leads. Another publication for a patient with perineal pain, dorsal root ganglion stimulation of the third sacral root. This is how it looks like. The interesting thing here is that the frequency of the stimulation is only 20 Hertz, is more or less the same frequency that we are using for patients with bladder problems or intestinal problems. And please have a look at the amplitude of stimulation. We are speaking here about picoamperes, not milliamperes. When we are working in the spinal cord stimulation field, we are working with milliamperes. In the sacral area with these DRG leads, we are working with picoamperes, so much less energy. A review article on DRG. The authors here find that if we're speaking about CRPS and pain, we have low quality evidence for this therapy. Very low quality evidence we have for chronic pelvic pain. This is something we should consider. This does not mean that the therapy does not work or that the results are not good. It simply means that we don't have enough publications in this area. Definitions. This is a very old article, 11 years ago, was published in 2013, but it's always important to keep in mind different definitions. And I would not like to read the whole table here, but for me it's really important. When you are reading the term sacral nerve stimulation, not all authors are meaning the same thing with this term. There are publications with sacral nerve stimulation in the title, and they mean only stimulation of the third sacral root. There are other publications that with this term, with sacral nerve stimulation, they are meaning that we stimulate at the same time 2, 3, or more sacral roots. So one should be careful and read the methods section of these papers just to understand what it's all about. And let's become a little bit more practical or surgical. There are different ways to place a lead if you want to stimulate the sacral rods. You have the anterograde way, so you are going via hiatus sacralis and you plant a lead with 4 or 8 contacts in the vicinity of the roots. We have the retrograde approach. You are doing a puncture in the lumbar area and you are bringing the lead from the lumbar area to the sacral area. And you also have the transforaminal approach. You're going through the foramen. Actually, this is the famous InterStim system of one specific company. With the transforaminal approach, you can stimulate only one root, usually the S3 root. Which are the advantages of the undergrade placement? If we go via hiatus sacralis, we can treat patients with pelvic pain and bladder and bowel dysfunction. Technically speaking, it is easier. It's easier to place the leads. We have less dislocations. We don't have any risk of spinal cord injury, but there are also some limitations. If you don't have an accessible sacral hiatus or the hiatus is absent, it could happen, rarely, but it could happen, you cannot place the leads. If you want to anchor the leads with plastical anchors, this might be uncomfortable for the patients when they are sitting down, and you could have some skin lesions or dehiscence. These are all aspects you should consider. These are very old photos from our archive. You see leads with only 4 contacts. You see the needles that the colleagues used for doing the puncture, retrograde, anterograde. This is how it looks like. This is a publication coming from 2011, retrograde placement. You see the placement of one lead with 4 contacts, and you see also the setting of the anodes and cathodes of the lead. And for the same article, you see 2 needles at the same time and 2 leads coming from the lumbar area to the sacral area and the corresponding programming with 3 cathodes and 1 anode. Adrocrate placement in the Korean Journal of Pain, you see 2 leads coming via hiatus sacralis and they are placed cranially. With these leads, with 8 contacts, you can actually stimulate all sacral roots, and this is a big advantage. Disadvantage, the system is not MRI compatible. You're not allowed to do an MRI after implanting such leads there. This is what we see in the operating room. You see the gluteal area, you see the needle we are using to do the puncture, and this animation shows exactly where we place our needle and our lead. You see that the space is pretty narrow, it's less than 1 centimeter, and this is how it looks like if you have a lateral image of the sacrum. This is how the lead looks like. Some more intraoperative images with 1 or 2 leads via hiatus sacralis. Once again, an undergrade placement in gluteal area, the punction, but here the indication is urinary retention. And this is the beauty of this therapy, because you can implant a lead to treat chronic pain, chronic pelvic pain, but at the same time, using the same leads and different contacts, you can also treat urinary retention or bowel problems as well. Some more pictures with 2 leads and the leads coming into the needles. This is what you see after the placement of the leads. Of course, there are 2 options here. You can implant 2 leads, one for the left side, one for the right side. But if the anatomy of the patient is pretty difficult, it would be enough to implant only 1 lead, but this lead should stay at the middle line. There are patients who have pelvic pain, but there are also patients who have at the same time radiculopathies, L5 or S1 radiculopathies. And this is a very good example. This is the typical patient who is coming to us with an instrumentation, with screws. In such patients, it's not always easy to place a lead, a spinal cord stimulation lead. Another approach would be to go through hiatus sacralis and place the lead laterally so you can cover the L5 and S1 nerve roots. Sacroiliac joint pain. An article coming from 2010. You see a lead only with four contacts there for the left side. And the patient, and this is interesting, after 16 months after the implantation of the system, uses this stimulation only 5 hours per day. And he takes medications, but not so many as before the surgery. We have patients with cochidinia. You can use a tonic stimulation, but also you can use a burst stimulation. Burst stimulation is a sub-perception stimulation without any tingling. There are packets of energy delivered, and according to some publications, the benefit of this art of stimulation is that at the same time can influence the medial and lateral pathway of pain, meaning we can influence the perception of pain, the somatic component of the pain, but also the cognitive and emotional aspects of pain. There are some meta-analyses. One of them shows that the clinical results are slightly better, but not statistically significant when we are using the caudal pathway, when we are going through hiatus sacralis as compared with the retrograde approach. But once again, statistically, it's not significant. What about sexual function? There are publications showing that we have with sacral neuromodulation a significant improvement in sexual function, but not in patients suffering from fecal incontinence. Another meta-analysis showing the pain improvement at 6, at 12 months, and 2 years after the implantation of the system, and the results are pretty good. Case series from Australia published 2017 for pelvic pain or pelvic organ dysfunction. And it's really interesting that most of the patients are saying that would have done it again, so they are satisfied with this therapy. There is a significant difference in the pain score after the implantation of the system. Most of the women who had the system used the system every day to stimulate day and night, and most of them had pelvic pain, but among them there were also women with bladder dysfunction, bowel dysfunction, and sexual dysfunction. If you have a look at these X-rays, you see some leads with many contacts. Some of them are implanted via hiatus sacralis. Some of them are transforaminal. You can do all these combinations, but please keep in mind if you use these 4 or 8 contact leads, transforaminal, it's an off-label use. Finland, 2020, another case series. What happens if we stimulate S3 and S4 for chronic pelvic pain? You see that most of the patients here in this series had endometriosis, and 75% of them, so 12 patients out of 14, had good overall results. Endometriosis, when we stimulate S3 and S4, and once again here in the table you see abdominal or pelvic pain. They are together as a category. Here it's about only 3 patients, but you see after 2.5 years, the patients say that they are much improved. 4 as a number means that they are much improved. We have also the option of peripheral nerve stimulation, PNS. We can place laparoscopically a lead in near the obturator nerve in a patient with obturator neuralgia. For example, you can place leads for the pudendal nerves and the S3 nerve roots if you have patients with pelvic pain and voiding dysfunction. If you combine these therapies, PNS, pudendal nerves, and SNS, sacral nerve roots, then you have more programming options, and possibly you increase your chances that you will succeed in reducing the pain and the dysfunction of these patients. This is the famous interesting system of a specific company. You see a lead with 4 contacts coming out of the S3 foramen. This is used only for patients with urinary problems or bowel problems, not for chronic pain, because simply this system can stimulate only one root. But if you have such patients, they might have back pain as well. And one of the options for treating back pain is the implantation of subcutaneous leads. The therapy is called peripheral nerve field stimulation. Before implanting such a system, it's always a good idea to check the first system, the sacral nerve stimulation system, because if you have a closer look here, you see that the lead is broken, but the lead is broken before our second surgery. This is something you should keep in mind in all types of surgeries. If the patient has already a system implanted, you should have an X-ray before starting operate on him or her again. Laparoscopic implantation of leads to the sacral plexus. If you have patients with pelvic pain and neurogenic bladder, you see that the colleagues here stimulated different routes, S1, S2, S3, in one patient also L5. This is another option. And you see that the pain score is reduced, the quality of life is increased, and the catastrophizing scales, the catastrophizing of this patient is also reduced. So the therapy really helps. This is a patient coming from our department with coccygodinia, back pain, and leg pain. She had tarl of cysts near the S2 root. So we couldn't place any leads via hiatus sacralis because of this tarl of cysts. That's why we tried with spinal cord stimulation. We see a lead with 16 conducts and 1 millimeter spacing with the tip of the lead at T1. The tip is located at the midline. This is really important. And after the trial and during the follow-ups, the patient can sit, can drive without pain. She doesn't take any medication anymore, and she has, of course, a better quality of life. And this is the MRI of this patient. You see in the second earlier the tarl of cysts at S2 level. Then you have another case. This is a case with pudendal neuralgia, female 74 years old. First, we tried a sacral nerve stimulation with two leads via hiatus sacralis. The coverage of the pain area was really good, but she had only a pain relief of 10%. So she was not satisfied, we were not satisfied. And we said, okay, let's try with spinal cord stimulation in this patient. You see the placement of the lead, a lead with 8 contacts with the tip at T10, once again at the midline, really important. And the patient now takes no medications. She can sit much better. She can walk and she can sleep without having to wake up because of her pain. Vulvodynia, this is a very sensitive topic. Prevalence is pretty high. 8% of women have vulvodynia, but less than 50% of women seek treatment for this problem, and only 1.5% are actually diagnosed with this condition. So in this patient, you see, she's a young woman, 36 years old, with a history of burning pain for 5 years. We placed the lead via hiatus sacralis at contact leads in the middle line, and the pain reduced to 50%. It was not gone, but she was satisfied. This is another patient with endometriosis. She had a history of multiple laparoscopic surgeries, 2013 to 2021. Then she had a lesion of the sacral plexus in 2021, hysterectomy 2017. She used to catheterize herself. And you see, we implanted here a lead in the middle line with 8 contacts, and the patient came back and told us that her pain reduced from 8 to 2. She didn't need any medication anymore. She had less attacks. She had attacks, but much less attacks. And the most important for her, she didn't have to catheterize anymore. This is quality of life. But some months later, she had also left groin and lower abdomen pain, especially when sitting or bearing weight. We added a spinal cord stimulation lead. You see the tip at T8, and with the lead via hiatus sacralis and the lead in the epidural space at T8, we could treat the pain of 2 different causes. And while I posted this talk on LinkedIn, You see, there was a woman there who liked it, and this woman wrote, as an endometriosis patient with a long and painful medical journey, I'm more than happy with my spinal cord stimulation and sacral nerve stimulation system. So they are really happy. It's not something that I'm telling you. There is proof there. Spinal cord stimulation is a great therapy, but we have many other options. We have the transcutaneous, we have the percutaneous tibial nerve stimulation, and this is a randomized control trial coming from 2023. And the authors found that the percutaneous tibial nerve stimulation provide a higher level of improvement in terms of pain and quality of life. It won't last long, but I would love to answer more things on this topic because this intrathecal therapy is a therapy that many physicians are ignoring or they are afraid of. And the intrathecal application of drugs is something not new. You see these publications coming from 1938. It's about alcohol. And we know that alcohol has a specific gravity which is lower than that of cerebrospinal fluid. This is why we have to place the patient in a suitable position so that alcohol goes into the subarachnoid place, but comes into contact with the posterior roots. This is our target, not the anterior ones, the posterior ones. This was something that was done many, many years ago. We don't do it anymore. The electrical therapy is therapy that we still offer to our patients. It's a very nice therapy. This is the famous PAC paper, Polyanagenetic Consensus Conference, published in 2017 in Neuromodulation Technology and the Neural Interface. And this table 6, you see indications for intrathecal drug delivery, and one of them is the abdominal pelvic pain. Once again, it's not a new therapy. Publication comes from 1984. Here, the authors are reporting on the intrathecal morphine for pelvic and sacral pain in a patient with cancer, and they use a subcutaneous reservoir to apply morphine. You can implant the catheter for this therapy also retrograde from the lumbar area to the sacral area. If you have cancer-related sacropelvic pain, you can use different drugs. Some colleagues are using local anesthetic, bupivacaine, others are using fentanyl, others using combinations of them. Please keep in mind, if you have an electrical pump, it's an off-label use to use a combination of drugs, and the only drugs that are allowed for pain is morphine and ziconotide. Motor cortex stimulation, pelvic and perineal pain, it's about 2 cases. It's not a big series. You see the pain score is reduced. The onset of perineal pain when the patients are seated is much later, so the patients benefit from this therapy and they are using not so many drugs. But once again, motor cortex stimulation is not the mainstay therapy for such problems. What about electroacupuncture? We have a randomized control trial in patients with chronic prostatitis and chronic pelvic pain syndrome. It seems that patients benefit from it. We have repetitive transcranial magnetic stimulation for patients with endometriosis. And this is the interesting thing here. The patients are saying that the pain reduction was there, but was modest. It was not really significant. But the impact on pain interference and gastrointestinal quality of life was perceived as beneficial. This is why, when we are treating patients with pain, it doesn't matter why they have pain, it's not about the intensity of pain. These NRS or VAS scores don't say anything on their own. You have to take into account the functionality of the patients, what the patients can do now after these therapies and what they couldn't do before these therapies. Then you're getting much more information. There's also the option of transcranial direct current stimulation for patients with endometriosis, and you see that the therapy is more effective than placebo. The question is here, why do you have a man in this photo, not a woman? We're speaking about endometriosis. Well, there are 2 ways to explain this. The first one is that they just needed somebody for the photo to show the system how it works. But please keep in mind that endometriosis is a condition that can also be found in men. It's really rare, but it could happen. Patients with endometriosis, another therapy is an hydrodissection. For example, pudendal nerves or posterior femoral cutaneous nerve. You can use cortisone, dexamethasone, or you can use a local anesthetic, lidocaine, and you see that the VAS score, the pain score, is reduced. You see also that the intercourse, the sleep, the workability is becoming better. Something new, transauricular vagus nerve stimulation in patients with endometriosis. This is also an option, and this therapy acts by reducing the inflammation. A very interesting article in Scientific Reports. If you have some time, you could have read. And even more interestingly, you can combine this transauricular vagus nerve stimulation with the respiratory cycle, and the results are even better. This one more interesting article. Please do read it if you have some time. It was published in Pain Medicine. Almost finished.
I understand nothing.
When we are treating patients with chronic pain, frequently we have the following problem. We don't know why the patients have pain, and sometimes we don't know how we can help these patients. When you have patients with abdominal pain and pelvic pain, the situation is even more complicated because many psychological issues or factors are also at play. And this is why we must be really careful. For the future now, we need different interventions with multimodal mechanisms if we want to be really successful. We need interventions that offer longevity in therapy without developing tolerance to the therapy. And our therapies must target not only the signal transmission, but also the signal modulation and processing. And this is why all these new types of waveforms are really useful. So, can we really help our patients with chronic pain? Sometimes it feels like on the left side on the monitor that the whole situation is helpless. But at least we should try, and at least in the end, the condition of the patient should be a little bit better than what we found in the beginning. Please also don't forget empathy. The physician empathy is really important. This is an interesting paper in JAMA network. It's about back pain, but the results, I'm sure they apply to all types of pain. So the authors here found that the patients had better outcomes, and these better outcomes were more strongly associated with physician empathy than with non-pharmacological treatments, opioids, or even lumbar spine surgery. Empathy is important not only for patients, but also for physicians, for colleagues, for nurses, for our team members. And this is something we published here in Germany. It was about burnout and dependence in surgeons and radiologists during the COVID pandemic. And we found that actually the problem was huge. This is why we should take care of ourselves as well, because empathy is the antitoxin of the soul. If you don't already follow the social media accounts of the Journal of Neuromodulation, I would invite you to do so. They are available on Facebook or on Twitter or Instagram. You can find really interesting articles there. If you'd like to read a book, Handbook of Neuromodulation, I'm involved here as an editor and an author, and the recent development spinal cord stimulation as an author could be interesting for you. If you have any questions, I would be glad to answer them. If not now, this is my email address. You can always send an email and I will get back to you. Thank you very much for your attention. Thank you very much for the invitation. I hope it was interesting. I hope you learned something. And please, if you have any questions, just ask them. Thank you very much.
Thank you very much, sir, for your wonderful talk and very insightful information that you have communicated. Sir, I've got so many messages, so many compliments, and people are sending you many thanks and wishes. Sir, there are also a couple of questions. Would you like me to proceed with just a few questions?
Yes, please.
Thank you very much. Dr. Ahmed Najjar wants to ask you, it's a little bit of different, but many thanks, Professor. What's your approach to thalamic pain post-stroke?
This is something completely different. Yes, this has nothing to do with sacral neuromodulation or pelvic pain or
Exactly.
abdominal pain. When we have patients with a stroke, so hemorrhage in thalamus, for example, there we have two problems. The first problem is pain. This pain is something you cannot treat with spinal cord stimulation. You cannot treat it with a pump. What you could try is motor cortex stimulation or deep brain stimulation. The results are not really good, but some patients benefit from it. The second problem that these patients are having is spasticity. And spasticity is really strong, severe, and for spasticity, you could implant a pump and fill it with baclofen.
Thank you very, very much, sir. Sir, there's also a question over here. Um, Regarding the semiology of pelvic pain, when should we go for a sacral stimulation or a conus medullaris stimulation?
Nice question. It depends on the cause, why the patient has pain. Both therapies have some advantages and some disadvantages. If you stimulate the sacral nerves, you're doing a peripheral nerve stimulation. The sacral roots, the sacral nerves are peripheral nerves. Okay. If you stimulate the spinal cord, then you're going one level upwards. This is spinal cord stimulation. This is not peripheral nerve stimulation. If you place a lead in the sacral area, the system is automatically not MRI compatible. If you place a lead epidurally, a T8, T9, T10, the system is MRI compatible. So I would answer this question in this way. If you want to maximize your chances to offer a substantial pain relief, I would go with sacral nerve stimulation, but I would explain to the patient that it won't be possible to have an MRI at some point. If you have an older patient, let's say somebody who is 75 years old, who already has a history of stroke, then I would never implant a system that it is not MRI compatible. Then I would go directly for spinal cord stimulation. Nevertheless, the common denominator is it doesn't matter if you offer sacral nerve stimulation or spinal cord stimulation, the pain has to be neuropathic. If it is nociceptive, our therapies are not going to work. Please also keep in mind, it's not always black or white. You can combine therapies. For example, you can implant a neurostimulator and implant a spinal cord stimulation lead and one sacral neuromodulation lead via hiatus sacralis. The system will not be MRI compatible, but you will have two therapies at the same time. You have a peripheral nerve stimulation and you have a spinal cord stimulation. Or you could combine a spinal cord stimulation therapy with a pump therapy. You can implant a catheter in the sacral area and apply a local anesthetic, for example, and at the same time, you can stimulate conus medullaris with an epidural lead. So we have to think in this case a little bit out of the box. These are difficult cases, really challenging cases. There is not a clear algorithm how to do in these cases. And as I showed you on case, we did a sacral nerve stimulation. We were sure that the patient will benefit from it. We could cover the pain area pretty well. Nevertheless, the patient had a pain relief of only 10%, and then we proceeded with spinal cord stimulation. The same thing could happen with spinal cord stimulation. You can place a lead, have a perfect coverage of the pain area, but no pain relief. Then you can proceed with sacral nerve stimulation. So the whole way of thinking in such cases, it's not simple and sometimes depends on the experience of the surgeon. I don't know if I answered your question.
Thank you very much, sir. It's a very elaborate answer that you have given, and I believe that everyone will be going through your talk again and again. Sir, I'm really grateful to you for this amazing talk, and I think that we have taken much of your time. But, sir, we are looking forward to it, to your next talk, especially, I believe, on some other topic because everyone is so much interested. So, I really wish to, sir, invite you again someday. I think next year, any day whenever it is convenient for you, for another talk on some other topic, because I think this topic has really gained a lot of hype among my regular attendees. So I'm so happy that you were here, and I really want to thank you again. And I really I really wish want to invite you again for another topic because it's going to be really interesting for everyone around.
With pleasure.
Thank you very, very much, sir. I'm so much grateful to you, and I hope to see you again. There are so many compliments for you. There are so many wishes and texts that have I've received, sir. Thank you very much for this very insightful talk, and I hope to see you next time again. So thank you
Thank
very
you.
much, sir. Oh, thank you very much, sir.
Have
So
a
see
nice
you
evening.
again. Have a very
Thank you
nice
very
day
much.
ahead, sir. Thank you very much. Thank you.
Bye
Bye,
bye.
sir. Bye
Bye.
bye.